Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research. And we're here to explore a wide range of topics with you through interviews with content experts.
Welcome everyone, this is Kevin MacPherson, and today we are reaching out across the pond to the UK to chat with Laura Finucane regarding her article entitled, "What is the diagnostic accuracy of red flags related to cauda equina syndrome when compared to magnetic resonance imaging, a systematic review?" This article was found in 2019 in Musculoskeletal Science and Practice. This is part of a larger research project that Laura leads for the International Federation of Orthopedic Manipulative Physical Therapists, more affectionately known as IFOMT, and is really goal-oriented towards developing a clinical reasoning framework for red flag conditions that clinicians can use in the real world. Now, Laura's background, she is currently a consulting physiotherapist specializing in spinal conditions. She does have a master's degree in neuromusculoskeletal physiotherapy and is a member of the Musculoskeletal Association of Chartered Physiotherapists in the UK, of which last year, 2018, she achieved fellowship status through her contributions to the profession, and then followed that up this year with another fellowship being awarded to her through the Chartered Society of Physiotherapy for her significant impact on the physiotherapy profession. Now, as you figured out, her special interest does revolve around serious pathology around the spine, and she has presented both nationally and internationally on this subject, in addition to the papers that she has published on the topic. She does also teach at the postgraduate level regarding this subject matter and is, in her spare time, the vice president for IFOMT, the organization I mentioned earlier, which is a subgroup of the World Confederation of Physical Therapists. Now, in addition to all these roles, she is also the education and training lead for advanced practitioners and physiotherapists that really her role ensures that clinicians maintain their competency and expertise to deliver service for a group in the UK titled the Sussex Musculoskeletal Partnership. And this sounds like a really unique partnership, especially compared to how healthcare is delivered in the United States. So before we get into the article, and has kind of a framework in which we can apply your research findings, Laura, do you mind really elaborating on what the Sussex Musculoskeletal Partnership is and what its overall goal is?
Yeah, thanks, Kevin. Thanks for the introduction. It's a very kind introduction. So in the UK, I work for an organisation which basically delivers care for musculoskeletal conditions from the GP right through to secondary care and sort of post-operative care. And so that service is very much integrated. So we have some physiotherapists sitting in GP practices looking at patients that would have ordinarily been seen by the GP, who then will signpost these patients, and that might be to physiotherapy. And we have a very big physiotherapy department where lots of rehabilitation is taking place and care and treatment, and that's also supported by advanced practitioners, so who will basically see those patients who haven't particularly responded well to perhaps a conservative management, and their role as advanced practitioners is to work out what next. What do we do with these patients who haven't really responded to that conservative management? So, and that might be for in my case, so as a spinal specialist, I will see those patients who've had a course of physiotherapy, and I might have to scan those patients. I might have to look at other ways of self-management for them, conservative management, or they might end up sitting in front of a surgeon. So all of that is really, really well joined up, which is one of the unique parts of what we do is that we have access to all of those things. And as you said, my role is really trying to make sure that clinicians are kind of working at the top of their license, so they're really delivering a good quality care to our people that we serve, basically.
So that's a really interesting practice concept and it's something that I hope to see more frequently created within the United States.
Yeah.
Especially like when I think about your article, and I'm going to ask you to give the synopsis as well as the results in a second. But when I think about the article, I do think about red flags, referral, and how nice is it to possibly be able to literally walk down the hall or at least have very close communication with those other practitioner types. That
Yeah.
seems like it's literally built into the structure of the Sussex group.
Yeah, and you're absolutely right. I think that's one of the big strengths for us as an organisation is that ability to, I mean, I was in work this morning, and there's knocks on my door to say, can I ask you about this patient, or and so there's such good connection, and it is really invaluable. Just to have that support is really, really helpful, I think.
That's something I do hope to see. So before we go too far down that rabbit hole, let's go ahead and talk about the project.
Yep.
And just give us just kind of a short overview of what it was and the results that you got for it.
Yeah. Okay. So we basically performed a systematic review that looked at a number of signs and symptoms that you would associate with cauda equina syndrome that were evaluated for their diagnostic accuracy in predicting cauda equina syndrome against MRI. So the aim was really to kind of identify those key clinical signs and symptoms that we could use in confidence to identify red flags associated with cauda equina syndrome. Which you'd think would be, well, how nice would that be if we could do that, really? And I think our results are really no different to other systematic reviews in this area, in that we concluded that there was no individual sign or symptom or clinical examination that you could use to diagnose cauda equina syndrome. And I think that's that's potentially, that sounds really challenging. Like, well, so what? And I suppose what we said was that you could use these results, but with caution. And actually, fundamentally, given the kind of seriousness of cauda equina syndrome, it doesn't change what we do currently. That ultimately, the project doesn't change what we do. We know that we have to have a low threshold, to refer these patients on that we suspect might have cauda equina syndrome. So it's not about throwing these things out. It's actually kind of just saying, well, we're not adding necessarily to the evidence. We're just kind of saying, well, this is what we know, and we have to use what we've got at this time in motion, really.
And when I think about the couple of cases that my co-clinicians have been able to pick up on, pretty much the key finding that they had was more of that bowel and bladder function. Did that pan out in the results as far as the stronger, or one of the stronger yet still relatively weak findings?
Yeah, so I guess so. One of the key, well, I suppose one of the findings that is slightly better is the reduction in sensation in the perianal area.
Mm-hmm.
So bladder and bowel, it's challenging because you can have changes to your bladder and bowel that are not related to cauda equina syndrome, and that's why it's so challenging, I think. So you kind of need to take that with a pinch of salt, I guess. But so sensation around the genital area and around that area seem to be stronger sensitivity, if you like.
Okay.
Yeah. Sorry, go on. Yeah.
No worries. So I will openly be honest, with practice in the U.S., there does tend to be more of a prudish approach to patients. I can honestly say I've never actually done a true sensory assessment in that region in my practice. Is that something that is commonly done by physiotherapists over in the UK, or is that something that oftentimes is deferred to another practitioner?
Yeah, that's a really good question. Actually, these are kind of conversations we're having currently with our clinicians. So I teach quite a lot on this with a couple of colleagues in the UK, Sue Greenhalgh and Chris Mercer, and so if we look at the standards of practice in the UK, one of the standards of practice is to do a digital rectal examination and to do sensory testing around the perianal area, and both of which are not, in terms of evidence for their use, are not particularly helpful. So if you look at digital rectal examination, for example, it's really challenging, and the evidence is not great. So you could argue, well, why do it? And one of the arguments to do it is that it currently is in the standards of practice. However, when we talk to the orthopedic surgeons, they all go, "Well, don't do it. It's a waste of time because it just doesn't really help you." So in my organisation, what we feel is that if you're going to do digital rectal examination, then you need to be competent. And if you're going to be competent, then you need to do it lots of times, and that's the challenge. So if you don't see many patients with suspected cauda equina syndrome, then you're not going to be competent. So you shouldn't do it, essentially. So with regards to sensation testing, we're taking the view that you do sensation testing on other parts of the body. So why is this any different, really? It's a similar process you're going to do, light touch, pinprick. It just happens to be in an area that is, as you say, it's a bit more embarrassing perhaps for the patient, but it's an important aspect of testing for cauda equina syndrome potentially, and it might help you to make a decision. It might not. It might make no difference at all. You may have already made that decision on the back of what that patient's telling you about their signs and symptoms. So the answer is yes, we do it, but there is a huge debate. And the biggest argument clinicians will say was, well, it's not going to change my management. And I completely agree with that. I don't think it does change management, but sometimes what it can help is to get that patient to the right place quickly with some evidence around, what's happening for that individual. And it can also, it can be a bit of a baseline. So if at the time that I test that sensation, it's normal, and by the time they get to A&E and it's changed, then we know that, it's changing rapidly. And therefore, something needs to be done fairly rapidly in order to get the patient sorted quickly.
So from the sounds of it, it seems like it's a good threshold to treat method of kind of pushing across that threshold. However, as you've already said, there's a low threshold. So my curiosity then stems again more around the system in the UK and seeing how that process is different. So for frame of reference, in the US, outside of really the military, there's not a lot of physios that are able to ask for an MRI. They don't create that. That's not a pathway for us. Yep. So my question is specific to the UK is, are physios able to order an MRI, which is that reference standard or that diagnostic standard? And if so, how much of the questions that the findings of your exam, how much does that really impact the process that they go through for a patient who may be presenting with CES?
Yeah. So the answer is that yes, we can request MRI scans. So our advanced practitioners can. Once they've completed competency levels and training within regards to that. But in relation to cauda equina syndrome, so just thinking about it, you have to have signs and symptoms of cauda equina syndrome, and you have to have evidence on the MRI for it to be positive, if you like. So the important bit here is that I can request an MRI scan, but it's the speed at which I can do that, actually. So I can request an urgent MRI scan. So urgent in the UK is it could be anywhere between 2 days and 5 days. Whereas for someone with cauda equina syndrome, actually what I want is it's really about on-the-day scan. You've got to be able to do an on-the-day scan if you're suspecting someone's got cauda equina syndrome, because we don't know how fast that can change. And if you're waiting 2 or 3 days and there is a change and we're not picking up on that, then we're opening this patient up to devastating consequences, of loss of their bladder and bowel control. So some services in the UK do have access to that emergency scan, but a lot of clinicians don't have access. So what we have to do is we send our patients to A&E, to the emergency department, and we're reliant on them to actually carry that out, essentially. So
And is that referral process to A&E, is that a phone call based
yeah,
referral? Is that something that you put somebody in an ambulance and send them over? How does that look?
yeah. So it depends really. It depends how scary it is, I guess. But so basically, if a patient sat in front of me in clinic, and I worked out, I felt that I suspected they had cauda equina syndrome, I would ring our emergency department and speak to the on-call registrar and have a conversation with them about the patient and say that I'm sending this patient to them. I write a letter which I give to the patient as well, and I send them to A&E if they're ambulant and they're happy to get there. I would blue light them, so if I would stick them in an ambulance if I felt that actually they couldn't get themselves there. But generally, because we're quite close to those hospitals, we're talking a few miles away, that it's pretty straightforward to get them there, essentially. So we ask them to go to present themselves with the letter, and that A&E are ready to accept them when they arrive.
So it sounds like you guys have a very good communication scheme built up. Is this across the entire health services system, or across the entire Sussex MSK group, or how does that?
So it's well, yes. I mean, it's the NHS, but I have to say, it sounds great. It sounds like that's fantastic, but it doesn't always work that way. so I can send someone to A&E, and sometimes they get bounced out of A&E without being investigated. So then that becomes problematic, because you're worried about that patient. What do you do with that patient that gets bounced out? And we have to be a bit pragmatic about it, because our pathway is through A&E. We expect them to investigate and to rule that out, to rule out cauda equina syndrome.
Mm-hmm.
And we have to trust that system. We have to make sure you say, well, okay, I accept that they've excluded it, and if that patient comes back into my service, then I can still scan them, but I have to have the confidence that they've been screened for cauda equina syndrome, which is challenging. So it doesn't always work. I've had situations where I had a patient who presented we got her to A&E. She went to A&E. They basically bounced her out, and she rang me and she said, no one's really told me what to do. And the person she saw said, well, you're a carer, you're bound to have back pain, go away. And I was really worried about this young lady, because I could see her tipping into full-blown cauda equina syndrome. She was just beginning to have some signs that were really worrying. So, and unfortunately at the time I was working in the hospital, and I had a good relationship with the radiologists, and they were able to scan her on the day. I just rang them and said, look, I am really worried. And as it transpired, she did have cauda equina syndrome. I was able to sit her in front of that orthopedic consultant on the day, who basically said to the young lady, well, go home and pack your bags, we need to operate. And then he said, actually, don't pack your bags, we're just going to do it now. And she did really well. But that could have been a completely different story for that person. So it is challenging. It's not as squeaky clean as it might sound.
And I've got a similar experience when I was working in a hospital system here, in that I had a patient who had a nodule in his neck that was around his area of complaint, and I referred him to the physician, or back to the referring physician, of which I had mentioned nodule. And the patient ends up coming back to me saying he was all cleared and whatnot. And I was like, this is pretty obviously not right. And it turned out that inside of the keyboard for the electronic note, it said that the patient's physio was reporting an enlarged nose, in that the D is right next to the S on the keyboard. So what should have been node ended up being nose.
Oh my goodness.
Luckily, I was able to get back on the phone, take him basically across the hall to where the physician was, and it did end up being a pretty nasty outcome. But
really, yeah.
Simply just sometimes that communication line, even though it's there, can be tough to work.
Yeah, No, absolutely. Yeah.
So,
Yeah.
so, um, so this is kind of more in reference to that diagnostic standard of the MRI.
Mm.
I've always been curious as to why the electrodiagnostic studies or some similar type of nerve conduction study isn't really the clinical gold reference as opposed to MRI, especially given the number of asymptomatic findings that you can see with various different lesions of the spine. What are your thoughts on that?
Yeah. So I think the answer to that is, and particularly, and I'm talking about the UK a little bit here, is that if you're looking at electro diagnostic studies, then the waiting times to have them done are very, very long. So we really struggle with picking these patients up, essentially, because it would just take too long to do it.
Mhm.
And I think it would just be really problematic to use things like that, particularly in the UK. It wouldn't help really. And I understand what you're saying. In terms of looking at MRI scans, we know that lots of patients will have. If you look at asymptomatic patients, they will have lots of changes on their MRI scan that are suggestive that they should have surgery. We also know that patients who are asymptomatic can have cauda equina compression and they have no symptoms. And we're not going to do anything about that because they don't have any signs and symptoms. Conversely, you've got patients who have potentially what we think are cauda equina syndrome symptoms, and they have nothing on their scan. This is it's not black and white. This is very grey area, and I think that's what's really challenging for us. Is there are so many different variables that play a part in trying to unravel some of these patients. If you look at simply you patients who have back pain and they're put on medication, you look at things like pregabalin and gabapentin, these neuropathic pain relief, it can cause retention of the bladder. You can have patients who have prostate problems that cause retention of their bladder. So that there are lots of different variables that are going to play as part of this, and this is why as clinicians we have to ask those questions to try and unravel some of that information. And it's just it's not a tick list. It's not a they've got this and they got this. It's the question behind the question that you need to ask. That if you ask them, is there is your bladder functioning normally, and they say no, well, you don't just think, well, they've got chronic equina syndrome. You've got to ask them, well, what is it? Why is it what's not functioning? How long has it been going on for? Does that correlate when their back pain came on? So there's lots of nuances around chronic equina syndrome. It's just not that simple, really.
So I'm kind of laughing a little bit on the inside here. I teach the differential diagnosis course for the University of Florida, which is ultimately mislabeled. It's really a screening for medical referral course. And one of the key things that we build into the course is role play for the students. And something that I've built into it is to intentionally have the students who are playing the patient be either very direct with a no, and even provide them some cues on body language that there's probably more questioning to be had,
Yeah.
or to be very very elusive with what the response is, specifically for what you're looking for, which ultimately sounds like you're trying to get a very robust clinical picture of that person in front of
Yeah.
you.
Yeah. Absolutely. I think it's when you think about the patient that's sat in front of you, and they've come to see you because they've got back pain and they're in agony. That what the reason they're there is because they're in pain, and you're suddenly asking them about their bladder and bowel and their sexual function. They're kind of looking at you going, why are you asking me these questions? What's that got to do with my back pain? I'm here because my back pain's really, it's really painful. And actually putting it into the context of why you're asking is really important, because it becomes meaningful. They just kind of look at you as if to say, you're kidding me. You're asking me if I'm having sexual activity, when I'm in agony. Look at me. So it's absolutely critically, this needs to be in the context of why you're asking. It's very easy to go, is your bladder and bowel all right? But, that's meaningless as well. It has to be, in context. So, yeah.
Yeah. And arguably, context can be created, or at least a movement towards a threshold to treat can be created by grouping findings together, or grouping a bunch of parts of that clinical picture together. And you allude to this in the study, in that there might be a method in which some of these tests may be grouped together to create a more stronger statement, either in favor of that diagnostic label of CES or against that diagnostic label of CS. So I've got two questions for that one. The first one is, were you just not able to provide that type of research in this project? And then the second question is, are there any specific things that in clinical practice, more your clinician hat, that really throw up the red flag for you with cauda equina syndrome?
Yeah, I think it's a tricky one to answer that, only in that in the study, no, we couldn't really say to you that if you use this combination, then it's more likely to be cauda equina syndrome. I think that's challenging. But intuitively, you'd think that a combination of these symptoms would probably be more likely that they've got cauda equina syndrome. And I think that's true. And I think that's true thinking about just the other kind of serious pathologies that we look at. So for example, malignancy. So if I was suspicious of somebody having metastatic bone disease, for example, and we look at the red flags associated with that, then one of the red flags for that would be a past history of cancer. Well, back pain and past history of cancer wouldn't be enough for me to trigger an MRI scan. But if they started to tell me, about some of their symptoms, other symptoms that they might have, so this combination's growing. So they're starting to tell me they've got some night pain, and they're starting to get unremitting pain. They're starting to develop some band-like pain. Those kind of, that information starts to make me think, yeah, so my threshold is getting lower and lower to actually do something for these patients, for this patient. And in a way, if I think about with the cauda equina, it's a bit similar, but I would still have a threshold to I would have a threshold to scan somebody, even if they presented with one symptom. So, and a classic one of these, and we've had these scenarios where a patient can say to you, they can say, no, my bladder and bowel's fine, that's all fine, that my sensation's fine, but I've noticed since my back pain, I'm unable to get an erection. That is a sign of cauda equina syndrome. So, are you going to ignore that, or are you going to send them to A&E? And the answer is probably yes, I am going to send them to A&E. And we've had scenarios like that, and they have had cauda equina syndrome. So it's a challenge. It is a challenge, but often what you will find is that they will tell you more than one thing. They'll tell you the onset of back pain. They're starting to get leg symptoms, which might be getting progressively worse. They're starting to perhaps notice a change in their function of passing water, for example, and it just starts to all add up essentially. So, and I think that's very common with lots of stuff that we look at. It's very rare that we would act on one symptom, but with cauda equina syndrome, my threshold is probably even lower.
And I speak to the students in reference to having low thresholds. Obviously, I tell them they need to identify as best they can a system, so be it a cardiovascular system, neurological in this case, or you could argue autonomic complaints. But one of the things that I try to tell them is, even with that low threshold, the fact that in the US anyway, the fact that you have screened them and noted something that you believe needs to be looked at more thoroughly by a different healthcare practitioner beats out the vast majority of individuals who show up to the emergency departments in the US. In fact, I think the stat is somewhere below 10% of patients that attend to the emergency department in the US are actually in a position where they need that service. So I always say, whether you had a low threshold or not, they're getting more screening by you than what they likely would
Yeah,
have got if they just attended by themselves, which is still better than the average individual going.
yeah, I completely agree. I think it's something we are good at. We should be good at.
So the next question is going to be a little bit controversial, and it is more just to get your thoughts on it. One of the things that I've noticed when I've done lit reviews for cauda equina syndrome is that it's kind of like act now, you got to act now, you have to act now. And I've always wondered if there are any studies that try to take more of a conservative, maybe non-surgical, anti-inflammatory based conservative approach to this, or is it kind of like, why risk it? Just get it taken care of. Which honestly, as a patient, I think I might be in that latter category than wanting to try the conservative route. But what are your thoughts
Yeah,
or your knowledge on that?
yeah. So uh, ultimately, I would say get it sorted. The litigation is it's the most litigious orthopedic condition, frankly, and I think that is growing. Um, so time is of the essence, if I'm honest. There is nothing to be gained from delaying diagnosis in this condition because you know you you you'll end up, if we just waited, then and they do develop these symptoms and they do end up with retention and they have surgery, then 80% of patients might do well if they're treated in a timely manner, but some don't do well, and then they're left with devastating consequences, of having to self-catheterize, manually evacuate their bowels, sexual function is altered. It's absolutely devastating for these patients. So I don't think that that's a sensible option at all to try and try and use a conservative management in this case.
And like I said, I
Yeah,
personally would
yeah,
not take that
no,
route, and I would
no,
definitely not tell my patients or recommend my patients take that route. But I've
no.
always just kind of had that resting in the back of my mind on how a lot of neurological, especially disc-related neurological complaints with passage of time tend to revert in most cases. But like I said, I'm not planning on nor going to recommend that anytime soon.
No, that's fair enough. Yeah.
So, as we talked about at the very beginning of the podcast, this is part of a larger project. Do you mind describing what the overall larger project that you're doing for IFOMT is? And also, if you've got any other projects that are coming out that our listeners should have an eye out for.
Yeah, so the reason we carried out this systematic review was because, as you said, I'm involved in this larger project that is really, we're looking to try to provide clinicians with a framework that's a clinically reasoning framework to help clinicians when they're faced with possible serious pathology. And we're looking specifically at cauda equina syndrome, malignancy, fracture, and spinal infection. And this is the reason we're doing this is because currently, if you look at the red flags that we use in practice, there are no definitions on how to use it. It's a kind of list of things that you're supposed to decide what to do with. We've attempted to look at diagnostic accuracy for lots of these red flags, but it's pretty poor. So you can't rely on the fact that if they do have a red flag and it happens, it's a red flag, then you can't rely on the fact that means they're going to have a serious pathology. And equally, if they don't have a red flag, it doesn't mean they won't have serious pathology either. So it's really difficult for clinicians to work out, what do I do? How do I manage this? So we're trying to take a very pragmatic view about this and using a multiple perspective, which will include looking at the current research data, looking at the diagnostic accuracy of some of these red flags. We're looking to seek expert opinion and really use a more qualitative perspective that's really centered around that sort of questioning and the development of strong clinical reasoning that clinicians need to have in order to get their way around some of this serious pathology. So that's what we're trying to do, and I think it will provide the clinicians with a much clearer sort of reasoning pathway, which will clarify what the role of the red flags, with less reliance on this quantitative and experimental evidence that really has really been shown to be lacking actually up until now. So that's what we're trying to do. We're so the systematic review was part of that process. So we looked at all four of those areas and did systematic reviews in those areas. We've gone out to the experts to clarify which of the red flags we should use for each of those conditions. And now what we're trying to do is we're trying to put some detail behind those red flags to make it more meaningful and for clinicians to think about them in the context of the patient that's sat in front of them. And once we've done that, we'll go out to a peer review, and we'll ask clinicians internationally to look at this framework and say, does this make sense? Is this useful for clinical practice? And we'll see what spins out of that. But I think it will be helpful at this point in time with the evidence that's out there currently.
I like this approach. It seems, I wouldn't say counter to, but I think of the OSPRO red flag and the tack they're taking, which is more of a ask all of the questions and then see which ones are associated with the individuals who ended up actually having something. And it doesn't have at least my reading of those articles don't have a specific malady or what's the term I'm looking for? Malicious disease process. It's just what are the things that we should be listening for regardless.
Yeah, and that is one approach, and that's a different way of looking at it, and I think that's fine too. I think there are lots of different ways of doing this. I think what we know is that with serious pathology, it's not black and white. They'll present in lots of different ways, and actually, it's trying to pick up on those nuances of what patients tell you, because often the patient will have the answers. I think and we just need to be careful that we just don't kind of go, yep, they've got that red flag, let's do something with it. That's not helpful. We know that, if you have your back pain, 80% of patients who have back pain will have at least one red flag. So, that's not helpful unless you put it into the context and then you work out whether that's relevant or not. And I suppose, if I had to give you an example, again, I would look at a past history of cancer, because, if you jump up and down every time someone comes through the door with a past history of cancer, then we probably end up scanning everybody. 1 in 5 people will have cancer. So that's not helpful. Yeah. So it's got to be in the context. Is that cancer? Is it likely to metastasize to the skeleton or not? And if it is, what's their risk of that happening? So there are lots of questions that need to be asked beyond just, do you have a past history of cancer? And that's what we're trying to develop is that, that questioning behind each of those red flags, essentially.
That reminds me of a student that I was working with a few years ago who came in and got really excited about the past history of cancer. And my first question to the student was, well, when was their last follow-up with the cancer specialist? And he's like, well, I don't know. And he ran back in the room and came back out and he said, it was about a month ago. And I'm like, well, I don't think this is a send to the emergency department situation.
Yeah, exactly.
Well, Laura, so the final couple of questions, not really related to the project. One we ask most of our fellows, and again, a lot of the interviews we've done so far have been more with a U.S. centricity to them. But if you had a young practitioner who is considering fellowship training or advanced practitioner certification, what would you do to kind of either recommend for or give them insight to that process?
Good question. So I think advanced, so the roles in the UK, advanced practice is really dealing with complexity, and I think my advice or my suggestion for an individual who asked me that would be keep your knowledge broad. I think we in some respects in the UK we've become too specialist in lots of areas, and actually if you look at the complexity of our patients that are coming through the door, they've got lots of comorbidities, and you need to have a broad understanding of those different comorbidities that's going on for that patient. So I would certainly say get grounding in sort of a general approach. It's fine to specialize, but you do need to have an understanding of those basic sort of generalist skills as well. I think that would be the key thing for me.
Huh. In reflecting on my training, I like, and I don't think I've ever thought of that being a outcome of the training, but I do think that now that I reflect on it, I do have more of a broader group of possibilities that are based off of that nuance that the patient is providing with their history or their story or the context in which they're presenting. So that it's interesting. It's almost like to become a specialist, you need to become a better generalist.
And I think that's right. If I look at my training, so I spent quite a lot of time, a number of years, going through other specialties like neurology and pediatrics and orthopedic. So real sort of generalist training, which has really sort of grounded me. I think it's given me a huge background. And whilst it's a long time ago, I can still remember some of those neuro patients, and I think it's been really helpful. So it's easy to specialize quickly, but I think sometimes you miss out that sort of grounding that's really important, I think.
And that's fantastic insight. So Laura, I'm sure that there are going to be some listeners that may have some follow-up questions for you or would like to get a little bit more information. Is there a better way for them to get a hold of you?
Yeah, they can email me. I'm very happy to be emailed, or I'm on Twitter. So I think you've probably got my Twitter handle. So it's Laura Finucane B. And do you want my email address?
Yeah, sure.
Yeah, so it's laura.finucane@nhs.net. So I'm very happy to have some questions.
And I'm sure there are going to be some listeners that send some. And I want to thank you for your time and all the work you're doing across this very important aspect of clinical practice. And I look forward to reading everything else that you're putting out in the future.
Thanks very much. It's a pleasure to speak to you. Thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.